I'll use this.
Now we are live on YouTube. We're starting in another. So good morning, dear delegates. Today we have Dr. Nita Radhakrishnan, ma'am, with us. She is head of the Department of Pediatric Hemato-Oncology at Postgraduate Institute of Child Health and Super Specialty Hospital, Noida. And she'll be speaking about the approach to a child with suspected primary immune deficiencies. Though this is still a neglected disease in India, but now we are getting more insights into it. And she is an expert. And I request her to please begin her presentation. Thank you.
Thank you, Dr. Ajay Gupta. Good morning, everybody. And first of all, congratulations to Delhi IAP for the organization of this wonderful course. I've got queries from people from all over the country asking whether they can be part of it and, whether such programs can be done in other states and so on. So kudos to the organizers who thought about it, and a very successful program indeed. So I have been asked to speak on approach to primary immune deficiencies, as in this, the evaluation part of it. So that's what we'll do in the next 1 hour. So primary immune deficiencies are now called inborn errors of immunity. They're called like inborn errors of metabolism. We are used to that terminology very commonly. So similar to that, it's called inborn errors of immunities now. They are all genetic disorders, and they are caused by variants in single genes, as in monogenic disorders. Individually, they're all rare diseases, and that's why, like Dr. Ajay just mentioned, these are disorders which have never been thought of earlier. We forget to put them in the differential diagnosis when we see patients, because many of the presentations are similar to what we see in other disorders. So maybe it starts off as something else and then ends up being something else. So individually, they are rare. And collectively, however, if you put all these disorders together, they are quite common. It's not that rare at all. And every year, we have more and more patients being picked up, more and more new diseases being diagnosed, especially thanks to the advent of next generation sequencing. Now we have many other modalities of testing, and that has improved diagnostics immensely. So when do we think of primary immune deficiencies? Again, traditionally, we were taught to think of only when a patient comes in with infections, unusual infections, recurrent infections, persistent infections, etc. But over the years, we have realized that it could be in patients who present with autoimmunities. So patients who have real difficult autoimmunity. So whichever system it is, it need not be hematology always. It could be patients who present with bad nephritis, patients who come in with autoimmune liver disease, for example. So any kind of autoimmunity, especially if it is refractory to 1 or 2 lines of therapy, if it is early presentation, repeated as in relapses happening, or family history of autoimmunity, all of them should be evaluated for an underlying, because these are all happening. Why? Because there is an defect in the immune system to control this autoimmune, the clone of cells, which is actually causing autoimmunity. Now, 3, it could also happen in patients with malignancies. Again, patients ask us every day why my child developed this cancer. So we've all been taught that cancer happens on its own. Very few conditions are there where cancer could be because of an underlying issue. But again, as we advance in our practice, we know more and more patients have underlying genetic mutations which cause this cancer, and this can have implications for the family, especially young parents who plan a next pregnancy. It could be there in autoinflammation. This new group of disorders which have been described as in the last maybe 1.5 decades, a lot of recognition has come in. And these disorders are essentially handled by rheumatologists, our rheumatology colleagues. So again, patients coming with recurrent fevers, recurrent joint involvement, throat, skin, these kind of presentation, we should be thinking that there may be an underlying inborn error of the immune system. Patients with allergies, again, bread and butter, like infections. This is another thing which comes up in practice, in pediatric practice, very, very frequently. So we'll see when it should be evaluated. And finally, new entry into this inborn error bubble is bone marrow failure. So that also has been added now, because they have realized that the infections that patients have with bone marrow failure are not related only to the neutropenia that we see commonly. It could be because of other issues as well. So these are conditions when we think of, and I'm not sure if you can see the last line of my slide. So this is something which I keep using everywhere. So the beginning and the end were always there, before the beginning and after the end. It's a very famous quote by T.S. Eliot. So what I mean by that is, whenever a patient is coming to us, when the patient is in front of us, we are dealing with one of these disorders, so maybe two of these disorders at the point of time. We really don't know why this happened and how this is going to evolve. So many a times, after a long period, we get to a diagnosis which explains every single thing that has happened in the past. So retrospectively, everybody is wiser. The challenge is to pick these things early so that you kind of get to a treatment before the child dies or succumbs to the illness, or before the child develops organ-limiting toxicity. Many a times it's after very bad lung disease or liver failure or gut involvement that we kind of pick up these disorders, and by then it's already, we've lost the game usually. So coming back to the classification. So this is the inborn error classification of IUIS classification of inborn errors of immunity. And this again increases every year. So this is the 2022 publication that I have cited here. So here you divide it into 10 groups. So earlier when I started seeing COP probably a decade ago. So at that time, there were 6 groups at that time, and slowly it has increased. So you can have inborn errors affecting cellular and humoral immunity. And here, again, to understand this, we need to have a basic concept of the immune system. So in basic immune system, you have innate and adaptive immunity. And in innate immunity, you have your neutrophils and phagocytic disorders and skin barriers, all that come here. And all the signaling pathways also come here. Whereas in the adaptive system, you have T cell and B cell mediated immunity. So if your T cells are defective, that is called a cellular immunity, immune disorder. So any immune deficiency affecting cellular and humoral immunity is considered the worst. And that is why it is on the top of the order. And the prototype is severe combined immune deficiency. Now, it could have combined immunodeficiency with syndromic features. So they are not your classical SCID patients. Classical SCID patients look like any other child. There is no syndromic feature. There is nothing written on the child that this is immune deficiency. Whereas, unlike other disorders, like for example, if for an average person or a clinician who is seeing, if you pick up these, many of the genetic disorders, you pick up from the facial features. Many of the hematological or other genetic disorders, you get to know from the findings. But here, these are disorders which do not have any stigmata associated with the disease. It's just an infection that the child is coming in with. That is why there is a challenge in picking up these disorders. So combined immune deficiency with syndromic features would include your patients like Wiskott-Aldrich, patients with DJOT syndrome. So these kind of disorders, immune deficiency is just a part of a bigger process. And that again helps us get to the diagnosis earlier. The third group is primary antibody deficiencies. So these include patients who have D cell disorders. We'll focus a bit on it because these are disorders which are going to come to general pediatric practice very, very frequently. As in, these are children who are going to present with symptoms which general pediatricians see very frequently. So I'm going to dwell on it a little more in detail. Disorders of immune dysregulation, which has many immune dysregulatory disorders, including HLH described in it. Disorders of phagocytic defect, number, function, or both. Again, relatively easy to pick up these disorders because phagocytic system, as you know, it would be neutrophils and macrophages. So in neutrophils, if you have neutropenia, neutrophilia, that's all you want to look for. So if neutropenia, again, easy bone marrow evaluation and gets to the final diagnosis, whichever type of congenital neutropenia it is. Neutrophilic disorders, again, whereas out of proportion neutrophilia, you know how to evaluate. That also is easy. And then functional disorders, patients are a bit neutrophilic, but there's nothing else abnormal in the neutrophil on a smear or anything else, then go ahead and evaluate for congenital chronic granulomatous disorders, as well as many other neutrophil function disorders. Then innate and intrinsic immune system disorders, very difficult to pick up because here there is nothing as a screening investigation available to us. So if at all you suspect, nowadays, we are actually going back to the diagnosis once we have a genetic report because signaling defects are so difficult to pick up. There is absolutely no screening test, and it's not cost effective to do flow cytometry for signaling evaluation. If you have a large research lab working on that particular disease, then it makes sense. Otherwise, for a routine flow cytometry lab, it does not make sense to screen every child for these disorders. Autoinflammatory disorders, complement, marrow failure, and the last kid on the block is phenocopys. So here what happens, they are actually not disorders which the genetic disorder is not there particularly, but there is something else which is causing autoimmunity, and that autoimmunity is directed against those genetic cells. So it behaves exactly like the disease, but it is actually an immune process, and that immune process is directed, and we need to identify that and treat those disorders. So very, very complicated list. And if you look at this classification, there's like charts. So this is free access paper, JCI paper. So there are tons of algorithms given in it, which gives you how to go one by one and all. So extremely difficult to remember each disorder. And like I said, every year, just 10 disorders or so get added to that list. So it's very complicated in itself. But this is something which has helped me in my practice. So this is an old paper before actually NGS took off so much. So this paper tells you how in practice we can actually look at these disorders. So we need to identify what is called patterns. And patterns help us in everywhere in medicine, and similarly in inborn errors of immunity. So patterns could be children coming with. So patterns help you get to a compartment of immune system. So that helps us narrow down our differentials easier. So you have patterns like, for example, ENT and airway infections or sinopulmonary infections. So these are very, very common infections in practice. And so when you see a patient, what are the possible differentials? What are the stepwise evaluation we should be doing? That is something we'll see today. The second pattern is just patient coming with failure to thrive. So again, failure to thrive, very, very important practice as a clue to pick up in practice. And it's not related to, many times we think it is related to a malabsorption or an allergy or a milk protein allergy, a lot of reasons to it. But if a child is actually coming to you with not gaining weight and infections, definitely should be evaluating for underlying primary immune deficiencies. Recurrent pyogenic infections. So this category has only bacterial infections, and they're coming back again and again with bacterial infections. Recurrent infections with unusual organisms or unusual severity. So that means there's something which never usually causes infection in a normal human being, or unless there is an immune compromise. For example, we very rarely hear Buckholderia capacia, or we very rarely hear Elizabeth Kingella. So these are infections, when you hear the name itself, okay, there's something odd. It has to be a line infection, it has to be a malignancy, or it has to be something else. It has to be HIV or else something, and that something is inborn errors of immunity. Recurrent infections with the same organism, child is otherwise well. So all children with immune deficiencies need not look sick, or they need not be failing to thrive. There are children who are absolutely well, and weight, in fact, everything is going on normally, but then just one specific infection they are not able to clear. For example, tuberculosis. This happens in Mendelian susceptibility to mycobacterial disorders. Otherwise, well, kids, just keep on getting tuberculosis. So one tuberculosis over treated, the second episode comes up, or tuberculosis with unusual severity. Somebody is getting osteoarticular tuberculosis, or a family history. So traditionally in tuberculosis, we were all taught during post-graduation that if a child comes with tuberculosis, I'm sure it is the same even now, that you look for overcrowding, family history, contact, all that we're asking, presuming that that is the reason why the child got tuberculosis. Here is something we're talking the other way around. That is, the tuberculosis is happening if it is happening in a family member and the child, rather than just thinking that is all exogenous, it could be there could be an endogenous cause as well. So that could be, like I've seen a father and a son with osteoarticular tuberculosis. So it's very, very rare to get that kind of presentation. So if we see presentations like repeated TB, TB coming in family members, clustering, or tuberculosis with unusual severity, definitely evaluate for underlying MSMID. So these are disorders which come like that. Similar to this, there could be predilection for HSV in meningitis. So again, there are TLR signaling defects where there are only HSV predilection. So that kind of defects can also come up. Autoimmune manifestation, like I said earlier, Early autoimmunity, refractory autoimmunity, autoimmunity in the family, these again evaluate. And finally, angioedema, which is pretty straightforward to evaluate. So whenever you have any patient coming to you, these are the 4 questions, again, that helps us in practice. One, when I'm focused from an PID perspective, then I'll be thinking, is there a non-immunological cause? But when the pediatrician is seeing the child with an infection, I think other than the normal non-immunological causes that we think of, an immunological cause should be added to the DD. You identify an organism whenever possible. So rather than giving antibiotics, maybe a culture helps in many scenarios. If at all, there can be, an organism that comes up, that organism helps us compartmentalize the infection very well. So that is helpful. Family history, and again, CSF also. Whenever you're doing meningitis workup, if the minute we do not get a bacterial, does not look bacterial, definitely send out PCRs, because it's helpful to know what virus it is, and that helps us narrow down the DDs. Family history and consanguinity. Again, very helpful practice pointers. One is family history. 3-generation family tree should be taken. And this 3-generation should include history, not just for infections or deaths. It should also include malignancies. It should also include autoimmunity. So this, when we take out this history, many times to our surprise, at times the young parent may not remember it in the first go. Then tell them that you think about it, go back, speak to your parents or speak to other family members. And we come back next, tell us whether there is anything that has happened. And we often see very beautiful family histories come out. So many children with SCID or X-linked disorders may have a family member of mother's brother having leukemia. So these kind of things which were earlier not linked, now gets linked because of the better understanding of IEI. And finally, are there any special features in the diagnosis which helps us in the diagnosis? For example, hypopigmentation, or for example, something which has come up in the blood test, like a reduced uric acid. All of these can actually point us to a final diagnosis. So I'm going to focus a bit on recurrent sinopulmonary infections, because these are extremely common in pediatric practice. And we know when we see a child with a sinopulmonary infection presentation, it is often for new practitioners difficult to differentiate between allergy, a simple infection versus allergy versus hyperactive airway disease. And you really need to draw a bar as to when should I think of underlying evaluation. Is this normal? Is this abnormal? And again, difficult to differentiate viral from bacterial infections. Extreme high fevers can come up in viral fever also. Need not have all the usual prodromal symptoms. And a lot of viral infections and a lot of respiratory infections can be normal in children as well. So again, it takes time to tell or convince the families that this is okay. Let's not do anything about it. But this is not okay at all. So then we need to evaluate. So that kind of understanding again comes with a time, maturity, etc. And respiratory symptoms also, once they come in, earlier we expect things to resolve in a week's time. Nowadays, we know that the cough can go on. It can take sometimes weeks to get resolved. Yeah. So most patients who come with sinopulmonary infections to a pediatric practice and an OPD practice actually do not have PID. So it's just normal things that are happening to children. If a child comes with recurrent infections, again, we need to think of non-pulmonological or non-immunological causes first, and then come back to seeing whether. So once you get to that stage, then you're decided to evaluate further. That is when, again, immunological issues as well as non-immunological issues would be done. And very, very important to diagnose this on time, because many times by the time the child comes and gets a diagnosis, it's already too late. The child may have exercise intolerance, may not be able to climb stairs, may require MDIs twice a day. These kind of presentations, because those repeated infections were never evaluated. And by the time our evaluation has done, that is quite late. So like they tell us, for non-immunological causes, identifying spur symptoms is helpful. If anything was severe, anything was persistent, unusual, or recurrent, definitely needs further evaluation. So severe would mean prolonged hospitalization, need for ventilation, multi-system involvement, needs evaluation. Persistent means clinical persistence of symptoms which never got improved, or radiologically there is a failure of resolution more than what we expected. That also, again, important. Unusual findings like unusual clinical findings, comorbidities, chest X-ray findings, unusual colonies as in unusual organisms that got identified, all these needs further evaluation. And recurrently having the same symptoms also needs evaluation further. So this is again one picture which I always find is helpful when we think of deciding whether to evaluate or not. So these kind of infections are usual, maybe once in 2 months or once in 6 weeks kind of infections presenting in a child may be normal. But if there is recurrent episodes, but everything improving and you may need to give bronchodilators, etc., but improving eventually, that is hyperactive airway. Patients having symptoms, but taking long time to clear. And by the time they clear, they end up with another infection. So that kind of presentation especially is helpful to identify primary immune deficiencies. A patient having prolonged injury, so some staphylococcal infections, etc., take a very, very long time to recover. This may be normal for that staph infection. Patients not improving at all. So that means either a congenital disorder, as some kind of disorder in the airway, a foreign body, all those things come up in this evaluation. So when is things abnormal? When are things normal? So there is this Jeffrey model warning signs which have been put out. Then again, a rider that this warning sign is actually being described for lay public. It's not even for pediatricians also. So, but then if these signs are there, the parent is supposed to bring the child to a hospital or the primary care provider, the primary care where the patient is being shown, that system should actually flag this and send the patient ahead to a pediatrician for evaluation. So warning signs in children, there are 10 warning signs. I won't go by the numbers because actually numbers don't make any sense. But in these warning signs, I think the animation is not coming up. So, but the most important in practice are 2. One is failure to thrive. And the second I had underlined family history of PID. So these 2 things, if there is a family history, which is not good, if there is a sibling death earlier, if there is somebody with the same symptoms, again, we should be alert to the possibility that this is not just a routine infection. 2, if the child is not growing normally at all, maybe went normal till 6 months and then started plateauing and then started falling off the centiles. So that is important. Or just didn't pick up at all. So that again, so that kind of picture. The first thing, the one which is normal till 6 months and then falling off, that you see in patients who have antibody deficiency, because the first 6 months you're covered by maternally transmitted, as in maternally transplacentally received immunoglobulin G. Whereas the second, where the child never had any good growth at all. From the beginning, child is repeatedly having infections. So that kind of presentation you will see in T cell disorders, so those combined disorders we saw earlier. And those are disorders where early infancy presentation is very common. Similarly, so these are not disorders just limited to children. These are commonly diagnosed in adults also nowadays. So here again, all these presentations should make us evaluate further. And again, here, the most important would be a family history of primary immune deficiency to help us. But just we'll read out these things just so that we remember. So these kind of infections, rhinopulmonary infections, which include ear infections, sinus infections, pneumonias, patients on antibiotics, but with little effect. Patients who has recurrent deep skin or organ abscesses. Here, very, very important is liver abscess. If a patient comes, nowadays the understanding is that even with one liver abscess, we should be evaluating for underlying phagocytic disorders, especially CGD. So that is something which cannot be missed out. And it's a relatively simple investigation. Anyway, we're giving long duration antibiotics and the family would be keen that to know why this happened in the first place. Patients coming in with thrush. Again, non-bottle fed babies or babies who have otherwise the family's hygiene is good, no fomite exposure, but still getting thrush, definitely evaluate. Baby failing to thrive and having thrush, even though there is a history of bottle feeding, still look at a CBC and an absolute lymphocyte count, because this is something which will very easily be picked up on a CBC, a SCID baby. So this presentation should be looked for. Needing IV antibiotic every time to clear infections, more than 2 deep-seated infections, including septicemia. These again are infections which are worthwhile evaluating. In adults, the number of infections change a little bit, but chronic diarrhea, weight loss or no weight gain, very, very important evaluation. And why I'm saying adult is because many times we do get young adults who come to even us for evaluation. So that these things should be kept in mind. And recurrent deep-seated abscess thrush, all that is similar for these patients as well. Now, come back to why this happens. So first of all, we'll be looking for whether there is a non-immunological cause or not. So under non-immunological causes, we again have been taught of thinking about the usual reasons why children develop infections. So it is usually a daycare exposure, a patient who has bronchial hyperactivity, allergies, adenoids, GER, passive smoking exposure. So then we methodically evaluate all this and give a checklist to the family to rule out all these things. And infrequently, so if this is not there, we know what to look for. We ask for foreign body history. We evaluate for bronchopulmonary fistula. We look for congenital anomalies in the bronchial alveolar system. We look for cystic fibrosis, ciliary dyskinesia, alpha-1 antitrypsin. All this evaluation starts. But I think before this point, when we're starting to think of CF and all, at that time, just a simple CBC and an immunoglobulin profile can pick up a lot of these disorders, which presents with repeated sinopulmonary infection. So this is something which we need to evaluate. And if at all, if there is an organism which is there, an organism usually that presents with recurrent sinopulmonary infections are usually Haemophilus influenzae, strep pneumonium or axilla, etc. It could be staph. So it's usually gram-positive organisms that are there in this thing. And along with that, antibody deficiency, patients have increased predisposition also to Giardia and also to viruses like enterovirus. So usually for all other viruses and as well as for tuberculosis, we need T-cell mediated immune system. Whereas here, enteroviral meningitis is something which we encounter. I'll show that in a bit. That is something where we need to evaluate for underlying antibody deficiency. Again, repeated episodes of diarrhea where Giardia is getting picked up, even if it is cryptosporidium T-cell disorder, Giardia B-cell disorder. So these kind of presentations are extremely, these are all just red flags, and immediately, as you see, get to an evaluation. So once you come to as an evaluation and you think of this is not non-immunological, let's think of immunological disorders. The top 3 differentials from that list would be a patient coming in with recurrent sinopulmonary infection. I would put antibody deficiency on top, combined deficiency at second, and third as phagocytic disorder. So I need evaluation to rule out these 3. Very simple evaluation, CBC, immunoglobulin profile. And if these 2 are normal, then you go for a phagocytic evaluation, which is called an NBT or a DHR. So that is what we'll be seeing, how to do all these tests. So CBC, immunoglobulin profile. And if the immunoglobulin profile is abnormal or if the CBC shows lymphopenia, then a lymphocyte subset analysis is helpful. And finally, if these are all normal, we are suspecting complement disorders, CH50, H50, as well as if we are suspecting phagocytic disorders, an NBT and a DHR. So what happens in B-cell disorders is, so this is how the B cells and the T cells are formed in our bone marrow. So there are defects which are very early in the system, which are intrinsic defects of the B-cell system per se. Then there are defects where the B cells are formed, but the B cells are not able to function because the crosstalk between T and B cells do not happen properly. And finally, there are disorders where the immunoglobulin production is defective. So it need not be hypogamma, pan-hypogamma. It could be just a subclass deficiency that can happen at these times. So this is how antibody deficiencies are described. And these disorders, patients will present either very early or with a little later, around 1 to 2 years of age, or later in life, like the end of first decade, they present with repeated infections, autoimmunity. So that is the classical presentation of common variable immune deficiency. So this is how, even chronologically, how does the patient present? So this is very early, this is a little later, and these are patients who are coming much later, maybe after 2 years of age. It could be usually by 5 to 10 years of age. So B cells, immunoglobulin profile, and flow cytometry helps us differentiate this whole cyanopulmonary group into 4 headings. One, we said XLA or X-linked A-gamma globulinemia, which is the earliest part, which is this part of the picture. So that is not produced because of the defect in the BTK gene here. It is usually X-linked disorders that you are there. And the second group is patients who present with CVID phenotype. The third group is hyper-IgM syndromes. And finally, you have patients with the selective IgA deficiencies, etc. A whole group of algorithms, as in this is how that paper describes it. The patients, these are the extreme group of disorders where this is how the evaluation has to happen. But again, like I said, it's impossible for anybody to remember all of these disorders. It's just that when you have a patient, you come to this, then you take out this and see what my patient fits into. And these days, it's often the other way around. Once you narrow down to a compartment, then you get evaluation done straight away for molecular testing. And once the molecular testing comes in, we see if if it is a pathogenic mutation, fine. If there is something new that is described, then we see what all can fit in, whether we should do family studies, all those is done accordingly. So this is the group of disorders, focusing a bit on antibody deficiency because these disorders are the ones who are coming to us with recurrent cyanopulmonary infections. So this is XLA or A-gamma globulinemia, classically described. Majority of patients have X-linked disorders, so this is XLA. It was described by a pediatrician, in patient who has recurrent episodes of meningitis and pneumonia. That's why it's called Bruton's A-gamma globulinemia. Hallmark is encapsulated pyogenic bacteria. So again, we just saw that, which are the organisms which are common. It would be pneumonia, sinusitis, bronchiectasis, as well as meningitis. It could be septic arthritis. Now, the thing about mycoplasma septic arthritis is many times you don't have a real evaluation possible to do that unless you do a PCR on it. So it's again missed. Many times it's just joint swelling, aspirated in. Some pleocytosis is there, culture did not show up anything, and then you don't end up giving a lot of antibiotics. It finally improves, but we really did not know what it was because of. And finally, chronic diarrhea because of Giardia lamblia. This is the infection profile of a patient with an antibody deficiency. Viral infections in the brain. So these are extremely important because many of these children, when they come with fever and meningeal symptoms, we usually think of it as either bacterial or tuberculosis or viral. Now, bacterial and tuberculosis, we get to know in evaluation from the CSF per se, but many a times viral, either the sample is not taken or the sample, nobody thinks about it, child improves after a couple of days, and then it's got again lost. But these children can have extremely bad viral meningitis outcomes. So if you see such patients, always keep a sample, as in for every meningitis that you see, always keep a sample which could go out for viral PCRs, because identifying this organism is often helpful to prevent the further one. So it could be any of the enteroviruses, but especially, Coxsackie, poliovirus as well. Why I'm dwelling a bit on poliovirus is that, so whenever, now there's a concept that if poliovirus is identified, so if a polio identification is happening in the community, we know that it is not, but even there are pockets which have polio excretion. So if it is getting excreted, it is getting excreted in the guts of patients who have antibody deficiency. So this is a very thought that started around a decade ago. Now there is a whole WHO program around it. Now we are all part of a couple of centers in India. We are part of a project from WHO and National Institute of Virology, where we are looking at stool carriage of enteroviruses in patients who have antibody deficiency. So now we have identified that the carriage can go up to, say, years together. So there are reports from the US. The US stopped polio virus, I think the oral polio virus vaccine, they stopped it around 2 decades or 3 decades ago. And even after that, they have patients who have carried it and then their gut carriage has gone on for 2-3 decades, and then they have developed meningoencephalitis later in patients who have an underlying CVID or some kind of antibody deficiency. I put up this case, which I was part of in the evaluation in Delhi. So this was the year when Delhi was declared polio-free. Just 2 months prior to that declaration, this baby presented. Actually, this is not an Indian patient. The patient came from Afghanistan, and the patient came in with fever and an element palsy of the lower limb. And when evaluating, so when you backtrack it, so this element palsy, whenever there is an acute flaccid paralysis, you're supposed to notify the polio surveillance team. So that notification happened. Parallelly, when the child was evaluated, the immunoglobulins came extremely low. So it was an XLA patient who had received oral polio virus in Afghanistan. And this polio virus, you cannot remove it because there is no luminal antibody in the gut. So that polio virus remains, it goes multiplications happen in that, multiple rounds of multiplication. And then there is a mutant strain that emerges out of it, which has neurovirulence, and that neurovirulence has caused this thing. And so this patient, this was notified to WHO, and this was also, this area was also contained, and all mop-up the vaccination was given before it was declared free. So it was the same year that it happened in Delhi. So this is about XLA patients. So XLA patients come with basically infections, sinopulmonary infections, gut carriage of Giardia, and viral meningitis as well. Now, second group of disorders, the ones where I said the B cells are formed, but the B cells are not functioning properly. So these children present with what is called CD40 or CD40 ligand deficiency. Here again, repeated bacterial infections, some autoimmunity, lymphoid hypoplasia, this kind of presentation can happen. So this is a 6-year-old boy, recurrent infections since infancy. So by the time the child so he's 6 years now. Now he's, 6 years when we saw him, and now he's almost 17 years. And he has had recurrent infections since early infancy, cellulitis, recurrent diarrhea, otitis media, recurrent right knee septic arthritis, one pus culture grew Staph aureus, but then after that, it's just been repeated episodes till 6 years. One pericardial effusion which got managed as tubercular. Again, many a times in our country, when we do not know what it is, we end up giving anti-tubercular treatment. So at presentation, there was just active inflammation of the knee. So if you look at the pedigree chart, here again, very easy to pick up from this pedigree chart that this is the child in question. The mother has a brother who has died. Mother has sisters who have boys who have died. So it's a clear-cut X-linked inheritance. An X-linked inheritance that starts early in life has only two differentials. One, the two differentials from an immunodeficiency point of view. It could either be an X-linked SCID or it could be an X-linked hyper-IgM disorder. If there is thrombocytopenia also, it could be an X-linked the other disorder like Wiskott-Aldrich also. So here we did the immunoglobulin profile. We saw that their immunoglobulin A and G were low, whereas, A and M were low, as well as G was in the normal range at that point. And eventually the G started increasing. So this disorder is called hyper-IgM syndrome. And this hyper-IgM syndrome, you can have patients who have relatively, as in these patients will have the B cell numbers may not be low. You may not be able to pick it up from a CBC, but when you start looking at the immunoglobulin profile, then you know that patients have low IgG and IgA, a normal IgM. And that is because in our body, IgM is formed first, and then there is a class switch that happens. And this class switch does not happen in this disorder because of this absence of this crosstalk between CD40 and 40 ligand. So the 40 ligand part is X-linked, whereas 40 is a autosomal recessive disorder. So you look at this in the this expression for CD40 ligand as done on flow cytometry. So you can look at it and can see that the child has absent expression of CD154. And if you look at the mother, she has reduced expression. So she is a carrier herself. So here again, it's very clear that the mother is a carrier from this picture because there is one child as well as another child in the family that has happened. So the same disease, if there is there in two children, then the mother has to be an obligate carrier. It is helpful for us for screening new families also. And the third group of disorders in antibody deficiency is called common variable immune deficiency. These are little milder things. So these things come up little later in life. So they do not present in infancy. Many a times they got wrongly labeled, especially if they are followed up in adult specialty clinics, because adult physicians or adult specialists see CVID way more frequently than pediatricians do. So it's very easy to brand it as CVID. It's like a basket diagnosis where we can't fit them anywhere. They get just branded as CVID. These disorders many of them present in adulthood only, but 33% can present in the first decade of life as well. And how do they come to us? Recurrent or chronic infections like otitis, bronchiectasis, and failure to thrive. Exactly what we described earlier. Autoimmunity as well as malignancy. So these are the common presentations of this. Again, variable age group, childhood to adulthood, but usually a little early, later adolescence and adulthood is the presentation. They can also present, other than the infection part of it, they can present with granulomas. So again, if you have granuloma, you have not identified AFB on it, please evaluate for two things. One is patients who have chronic granulomatous disorder, very easily can be picked up on NBT. And second, patients who have CVID very easily can be picked up on an immunoglobulin profile. So rather than just putting them on ATT and watching, many times symptoms may even improve also because they may not be as difficult earlier on, and they just may have waxing waning course. So many times you do find an improvement as well, but then the next time you find an infection, it with a granuloma, this thing, it might be too late at that time. So that is why whenever you don't have a definitive evidence of tuberculosis like a CB-NAT or an AFP, always evaluate further. These children can also present with interstitial pneumonitis. They can present with gastrointestinal infective inflammatory disorders in the gut, with tonsils, etc. would be normal, and sometimes they can have autoimmunity with autoimmune hemolytic anemia, thrombocytopenia, splenomegaly, this kind of presentation as well. And the least in that group would be selective immunoglobulin deficiencies. I'm just putting out IgA deficiency because it's so common and people misinterpret IgA being low to a lot of things. So IgA low can be seen very commonly in actually Caucasian population. It is seen as much as 1 in 100 normal individuals have low IgA, but all of these IgA is not pathogenically deficient. So if you have IgA low patients and they are coming in with infections, otitis, autoimmunity, celiac, that kind of presentation, they require further evaluation. And some of these patients in that last part of that picture, the immunoglobulin subclass deficiencies, IgA deficiency, all of them present with infectious profile, but their total immunoglobulins may be low. So if you are stuck with those kind of patients, then definitely it makes sense. So if you have immune deficiencies, but immunoglobulins come back as normal, so then there is again a list of things to do in those group of patients. So I'm skipping these slides because again, these are all there in that paper and very difficult to remember it otherwise, but you need to know how to compartmentalize that infection, and that is half the battle won for us. So this is a girl who was with us, as in she presented around 15 years of age or so, and she is symptomatic from 2 months of age. And 2 months of age, this recurrent respiratory infections managed on multiple antibiotics, multiple inhalers, and she was on these 3 agents when she came to us. And again, difficult to sleep at night. She has to put a pillow to sit and sleep, not able to climb stairs, not going to school. So that kind of a presentation with failing to thrive. So it's not something normal at all. 2, these kind of skin lesions again started appearing. So this pyodoma kind of lesions come up. And then when they are all biopsied, all of them showed granuloma. So, and then evaluated at multiple centers. And all these granuloma, she received around 3 or 4 courses of ATT before she came to us. So every time a granuloma gets reported, ATT is started because there's nothing else to give. So, and she came to us actually with an autoimmune hemolytic anemia. And by the time she came to us, it's again, so by the time this happened, so this episode of meningitis happened, she was evaluated and found to have low immunoglobulin. She got branded as CVID and started on immunoglobulin replacement. So when she came to us at around 15 years of age, actually there was nothing much in the screening evaluation that could have helped us. IgG was on the normal side because she was on IgG replacement, but we can see that IgA and M are low. So when IgA and M are low and IgG was low because of replacement. So you have hypogamma, but nothing much in the CBC, as in no lymphopenia asset and the CBC. Then we went ahead with the lymphocyte evaluation. She already had a report as well, which showed low B cells outside. So the diagnosis for which she came to us was CVID with autoimmune hemolytic anemia. But then here, what were the red herrings for CVID? CVID, like we said in that picture, is something that comes a little later. So this is not something you expect in a 2-month-old child. If a 2-month is coming with this presentation, the 2-month-old baby should have enough immunoglobulins from the mother. So that has not happened. So then there is something defective in the combined immune system. That is, the T lymphocyte system should be defective. Again, the red herring was there were granulomas without organisms and patients with having infections repeatedly despite being on anti-IVIG prophylaxis. So this was the final diagnosis of her. She had RAG1 mutation in a homozygous state. So this is extremely pathogenic mutation. So this is actually a SCID mutation. And why was it important to pick up? Because CVID is generally managed only with IgG replacements, antibiotics, etc. Whereas SCID is something which should have been picked up earlier and transplanted earlier. By the time you are 15 years old, a lot of organ toxicity that has happened, then it becomes difficult to treat those children. And again, you're just left with whatever we treat is just a palliative intent that we are giving. So when should we suspect IEI? In infections which are recurrent, infections which are of unusual severity, in any patient coming in with recurrent milk allergies or chronic diarrhea. So all SCID babies, when we see, they usually have a diagnosis of a prior gut-related agent. The chronic diarrhea is one main common presentation of SCID babies. And for this chronic diarrhea, they would have seen multiple doctors and they would all advise, doodh band kar lo. So when you stop milk and then you stop, you put them on soya preparations or pre-digested formula, etc. And it's still not getting improved, or just temporary improvement, then they go back again. So these chronic diarrheas in SCID kind of presentation is usually resistant viral infections in the gut. So that is not going to improve with anything unless T lymphocytes are replaced, that is through BMT. So this, the mother classically giving this example, this child is never well. One infection, the other happens, the next infections, and chronically this happening and child failing to thrive. Very, very important that we need to evaluate further. Some pictures. So these are children. So again, unusual severity of infections. So this is a girl. The middle picture is of a colostomy wound. So this baby was, as in mother gives classical history, that again, the animation is not there, other should have come up one by one. So this picture at the back is actually that of an infection. Actually, she gets these skin infections, which are very, very, as in it looks like a vesicle, and there is a serosanguinous fluid that comes out of it. And every time there is minimal inflammation around it. And whenever she is given amoxicillin clavulanic acid, which is our usual medicine for all skin infections, and generally she improves. So this happened for quite a while. And then she went with a similar perianal infection. And she started off with that. They gave the same antibiotic. This time it did not improve. And then by the time she presented to a medical college hospital, this it had already gone in for necrotizing lesion there, and she had to undergo a sigmoidectomy with a colostomy. So she still walks around with a colostomy. And later when you evaluate her, it is just neutropenia, severe congenital neutropenia that has happened. And that was the disorder. And that is why she is presented. Here you can see orbital cellulitis, again, in another child who was presented with the same disease, that is severe congenital neutropenia. So these disorders can be easily picked up from a CBC. The CBC will show total WBC count will be normal, but neutrophil count will be less than 100 usually. This is a baby. I'm not sure if you can see properly. Where I'm putting the arrow, there is a palatal perforation. And here even this lesion, this dirty looking lesion had ended up with the nasal bone getting perforated, nasal cartilage getting perforated. So this unusual severity of infections should make us wonder. And this baby also had an ileum mutation causing severe congenital neutropenia. So unusual infections is one. Thrush we already saw. Patients who come in with infection with no thymus in the X-ray, very, very important. Babies who come with seborrheic dermatitis with infections. Again, that is a classical presentation of what is called Omen syndrome. That is a typical type of variant of SCID that presents a little later with a lot of other presentations other than infection. So these are lymph nodes with Staph aureus in it, and this is seborrhea, typical presentation for a Omen syndrome or a SCID baby. Wiskott-Aldrich syndrome, this boy is big now, and he this was the earlier time, when you have an unusual infection and that has required like wide excision and clearance, etc. This is a patient who is present with warts and pneumonia. So these are small black warts, which have actually this hyper and hypopigmented areas you can see. And this baby presented, actually this boy presented with myeloid leukemia as well. And this was later diagnosed as Gata2 deficiency, again a combined disorder that you can see. Disseminated molluscum. So these are disorders of, this child has an IBD phenotype. So inflammatory bowel disease with disseminated molluscum warts. This deficiency is called Camel2 deficiency. This is again one of the monogenic disorders. Telangiectasia with pneumonia, very easy. Again, B antibody deficiency, ataxia telangiectasia. And then patients who present with unusually bad infections. So Candida tropicalis, bad pneumonias with pneumothorax in children with the patients who present with this boy had acute lymphoblastic leukemia also, and that deficiency is called SAMD9L mutation. So in autoimmune spectrum, when do we suspect autoimmunity? Like I've been repeating since the beginning, young age, refractory recurrent autoimmunity of any autoimmune disorder. It need not be pertaining to the hematological system at all. So even skin autoimmunity, like patients coming in with vitiligo, very, very important to evaluate. If they have persistent disorder, if they're not improving at all, or family history of vitiligo, etc., get them evaluated, because it's now we are in a phase where we are diagnosing more and more disorders just because we are able to evaluate them better. If you have two organ involvement, so I think I have a picture. Yeah, this boy, he has vitiligo as in hypopigmentation along with autoimmune hemolytic anemia. And this again is a hypomorphic SCID. And this is kind of skin lesions like, it's not exactly like HSP, but this kind of nodular lesions which come up in a child with infection. So this boy is also had. So these are actually not infective lesions. They are immunological or vasculitic lesions that come. HSP, it's a leukocytoclastic vasculitis in the biopsy, but then later diagnosed as SCID diseases. And finally, about allergies. If you have early age of allergy, resistance to first line of treatment, multiple types of allergies which are noted, then again, need to evaluate. So now I'm opening a Pandora's box whenever I say allergies, because there are so many tests available and I honestly don't know how to evaluate for it as well. But allergies are a presentation. And if you have patients, especially who are failing to thrive or allergies with infection, this kind of a presentation, definitely evaluate them. So this was a worldwide survey that was done and published a couple of years ago on allergic manifestations in inborn errors of immunity from India, where we had submitted along with BJ Chandigarh. So overall, in patients among inborn errors of immunity, up to 68%, up to 70% patients actually had even allergic manifestations on board. So it's not rare at all. It's extremely common. And comparison, it could be food allergy, it could be allergic rhinitis, it could be bronchial asthma, it could be atopic dermatitis, anaphylaxis, any kind of presentation also. And the allergy part of presentation actually would have delayed the diagnosis of inborn errors, because many a times for the allergy also you're giving them some treatment which is actually improving symptoms, and then they don't get evaluated further. So these are three main ways in which they present. And I'm skipping malignancy, autoinflammation, etc., because they come to specific subspecialties only. And again, evaluation is important in those children, but I'm skipping it for the want of time. So when you have a patient, how do we go step by step? So age of the onset, like I said, if it comes within 6 months, that means it's a very severe disorder. The presentation starts early. So that means either it is completely absent T cells or it is completely absent phagocytic system that is causing it. So very easy to evaluate also at that time, because most of the testing can be even evident on a CBC per se. If it's a boy who is affected, if there are other boys in the family who are affected, then important, and that helps us narrow down the differentials easily. So a third generation pedigree chart is important. So early neonatal presentation, as a neonatal with early infancy presentation, it's either T cell disorder or phagocytic disorders usually. So SCID, DGH, CD40, all of them come in this group. And phagocytic disorders, you have leukocyte addition disorders or CGD, which is the more common disorder that we see. Children after 6 months till early childhood, if they are presenting, this is the classical age when they present with antibody deficiency. Again, for us, this is the classical age where pediatricians are seeing them with recurrent respiratory infections. So one of those infections may be this, and it's quite easy if you just ask for an immunoglobulin A, G, and M. It's not difficult at all. Before we go on to all the other fancy investigation for recurrent respiratory infections, an immunoglobulin profile with a CBC with differential helps us narrow down differentials quite well. And finally, older age, these are disorders which are not so severe. So the child has lived, it allows you to live for 5 years with these diseases, and it could be CVID, specific antibody, etc. Why I said no severe is because the kid babies and all, they don't survive beyond 1 to 2 years of age at all. So that is again one reason that we need to be evaluating them very urgently. Because if you see lymphopenia and then decide, okay, next time let me see if it is not improving, then I'll evaluate further. Many times they don't even survive that long. So that becomes important. It becomes important to think about it and document it in the file, at least if you're not testing, because the next time if they end up in another center, it should be evaluated at once. I have had, I've seen children where we have advised testing, not testing done, and straight away, the next thing you hear is after a couple of years that they know that another baby has born now, and that baby has exactly the same symptoms. So the first one died in between in another hospital. And many times families come after losing 2 to 3 babies for a diagnosis where no sample of the index case or no evaluation of the index case was done. So these things happen commonly. So that is why it is important to evaluate quickly, one. And if at all evaluation is not possible, or the family cannot afford it at all, even the DNA can be stored. So many centers can allow a DNA storage to happen. So that costs, I think, 800 rupees or so. So that DNA, and many centers with research protocols in place, they can even do it free of cost. So if DNA can be isolated and stored, that evaluation can be done at a later date, especially in critically ill babies, where testing is not possible at that point, of family is not in the frame of mind to test. This again can be considered. Now, stepwise evaluation. So first is complete blood count, lymphopenia, very, very important, red flag for picking up these babies with T-cell disorders. So if you remember our CBC, just come to a CBC, yeah. So if you remember our CBC with differentials, are a major chunk of our, so if in babies, especially in young babies, if we see, we'll have lymphocytosis to the tune of 60-70% in young babies till the time they're 5 to 6 years. And after that, it is neutrophils that they take over. So if you see lymphopenia in young babies, that is very, very important, and that has to be evaluated. In a slightly older child also, this lymphopenia should never be compared across to an adult control. That is where we usually go wrong. Because labs which are reporting adult and pediatric samples together, they will just give a normal adult control against it, unless it's a very good lab and they think about this. But usually adult reports are given, and lymphocytosis, as we know, is an age-related phenomenon. And lymphopenia, because of that, never gets reported or never gets flagged in reports. So that is why we need, as pediatricians, we should be looking at lymphocyte counts very importantly. And we even advocate lymphocyte count to be checked before the first dose of oral polio vaccine is given, and even BCG is given. So again, easier said than done. To bring it as a national policy or bring it into a kind of a system where CBC gets checked every time. In a country where hypothyroidism evaluation itself is not possible as a government policy, it's not possible in all states, where hypothyroidism is way more common than these disorders. It's very difficult to make CBC be differential as part of a routine testing process before vaccination. Extremely difficult. But I think as practitioners who see patients there is some who will listen to us, and then you can get back and see the report before doing it. I think this is something which can be routinely practiced. So if any child in that period has an ALC, absolute lymphocyte count, of less than 1,000, that is very, very important, and that should be flagged, and that needs further evaluation. And these children should not receive any live vaccines till the time that the underlying disorder is ruled out. That is one. Second, So in lymphopenia, what does it pick up? Lymphocytopenia especially picks up a T lymphopenia, because B cells again are a very small fraction of the lymphocyte count. So B lymphopenias do not get picked up on an absolute lymphocyte count number, but T lymphocyte, that is a SCID group of disorders, get picked up, and that is very important to rule them out. The second thing what you can look for in the CBC is neutropenia. Again, severe neutropenias have been missed. All the time it gets missed. So that is something which we should be careful. Many children who go to surgeries, I'm sure there are centers even now that are just looking for a CBC platelet before surgery or a CBC TLC platelet. So all that is very, very wrong. If you have taken up a patient for surgery, we need to have a proper differential count also. Because why? Because that wound will never heal if there is severe neutropenia. So that has to be seen. So many a times, like this girl, for example, who went into all this colostomy and sigmoid and all resection and all, never had a lymphocyte count was never, neutrophil count was never picked up on it at that point. Later, the diagnosis was made after so many years, and the wound healing took a good 2-3 months as well. So this is important in that setting, and she could have died of a secondary infection at that point of time as well. So neutropenia, lymphopenia, always watch out. There is one more cytopenia that is important in a tuberculosis setting, that is monocytopenia. So if you have monocytes being very low, child presenting with tuberculosis, again, needs to be evaluated for underlying MSMT. A good peripheral smear helps us rule out a lot of other things, not very helpful in primary immune deficiency, only helpful in certain small disorders like HLH group of disorders. It helps us pick up granules, inclusion bodies, etc. in certain disorders. That is helpful. Thrombocytopenia, it is helpful. Shidak Higashi, that kind of group of disorders, it is helpful. And finally, HIV, if you look at by antibody testing, we may miss, because these children are not mounting an antibody response at all. So because of that, antibody testing may not be helpful. So we need to have some molecular way of diagnosing HIV. So this is the second group. So again, the animation part, I'm sorry about this. So these are the second and the third investigation. The second group of evaluation is immunoglobulin assays. We ask for all four, that is immunoglobulin GAME, call it GAME. All of the four things should be evaluated. GAM gets reduced and E will be increased. And so this is the usual pattern that we see. E may also be reduced, but E is increased in a certain subset of disorders where we are interested. Like, for example, patients with Oman, Viscott, etc. E may be increased. Third group of evaluation would be lymphocyte subset analysis. That was behind this animation. So lymphocyte subset analysis, we look for what is called TBNK. This is the basic subset that we do. So it looks at T cells, we look at by CD3, B cells, we look at by CD19, and NK cell by CD1656. Till now, we never had a normal control against which you could compare it. This paper came out a couple of years ago from Dr. Manisha's group, and it's basically an ICMR study. And this ICMR study finally gave us age-related lymphocyte counts, and this was published in Indian Pediatrics, and again available free access is there. So with this we know, now our lab also, we have a chart against every CBC. Till now we were dependent on US charts for reporting. Now we have this one, so we report it against this normal lymphocyte count. So we know whether this is low or normal. So now how do we see the next part? So we look at the lymphocyte count. So once you have lymphocyte count, the first thing that's CD3, so this is a panel, it's just a closed system that is getting tested. So you don't have to do anything. You put the sample, the machine gives you out the report saying that this is a CD3, this is CD4, 8, this is 1556, and this is CD90. So based on that, now we see whether this is normal, abnormal. If it is abnormal, if it is low, then you evaluate further. So you look at T cell numbers. If it is very low, it is in the SCID group. If it is low, it is in the combined immune deficiency group. And there is a small subset where T cell number is normal, but it still could be SCID. And these are because of some certain conditions. So if you have very low numbers that are SCID, so this is usually always T minus. Now, once it is T minus, then you look at whether this is the B cells are present or absent. And if B cells are present or absent, you look at further whether NK cells are present or absent. So you have different subclasses which come out of it. And that will tell us which group of disorders they are. Again, these are all animation slides. So that is why it's all projecting on together, because it's a different mode this time. But again, easy to diagnose, as it's not so difficult also. So you have TB minus, but T minus, B plus, NK minus, T minus, B plus, NK plus. These are specific subsets of primary immune deficiency. Not so much important, but the minute you have this T minus coming up, the next thing what we do is to evaluate urgently and start on treatment for SCID, because these children don't survive much longer, and get to a diagnosis, get to transplant at the earliest. So that is the gist of this slide. If children are presenting with near normal or low normal T cells, not very low, then combined immune deficiency, the second group of disorders here again, which has CD40, 40 ligand, MHC, all those group of disorders get picked up here. So this is the ECID diagnostic criteria. So the typical SCID will have absent T cells of CD3 less than 300. Many times we don't see that low numbers, or many times children who have that low numbers don't survive enough to come to a hospital, or they get just, die of the first infection itself. So by the time, as in if children you are presenting later, 1 or 2 years of age, they are usually hypomorphic mutations, which may have a little higher neutrophil count as well. So this is a classical example. If you can see lymphocyte count. So this is a baby, a boy who presented around 1 year of age with recurrent episodes of pneumonia and 1 episode of meningitis, and he had thrush as well. He evaluated in Nita, and this child was picked up by a pediatric colleague and referred for evaluation further. So this lymphocyte, when this came up, the pediatrician had evaluated, asked for an immunoglobulin profile, which showed low IgA, IgG, and IgM. So when we run the flow report, so you can see that the CD3 numbers, so this is 9. So let's first of all look at the lymphocyte. So lymphocyte count here, see the WBC count is 2,600 on a CBC report. The neutrophils is 2,190 and lymphocyte is around 300. And these two tests were done on 2 different days. And probably that is why here the lymphocyte captured is 758. And out of that, you can see that the CD3 number is just 9. So 758 per se is very, very low. So if a child at like 1 year of age should have an absolute lymphocyte count should be around 5,000 or 6,000 at that point. That is not, at least minimum at that point. So anything less than 3,000 is abnormal, and less than 1,000 is like a red flag. You will evaluate immediately. So you can see almost absent CD3, absent NK cells. So that 1656 is NK cell, that is also absent. And CD19 is present, that is B cells are present. So it comes to this group of disorders, which is T minus here, T minus, B plus, and NK minus. This is common gamma chain disorder, which is X-linked SCID. So there was a family history also. And this family actually decided not to treat further, and the baby succumbed after a couple of months at home. So whenever, again, that is a challenge in primary immune deficiencies, because unlike thalassemias or disorders where you know that there is time and then you can counsel and the family mentally prepares themselves for a big testing, like a big procedure like bone marrow transplant. Here are disorders where you are just diagnosing and tell them unless you do it, the child will not survive. So many families, financial is one aspect. Many of them, even if do not have financial issues or financially government gives support, even after that, they don't agree for testing because it is too big a decision for them to do very early in life. So this is how the scatter plot looks like. The step 4 is so that we reach till lymphocyte subsets. Along with this, you could look at the phenotype. So like initially we described the phenotype of these disorders. So if you suspect phagocytic disorders and your CBC is showing neutropenia, then definitely go ahead with bone marrow aspiration and biopsy. But if CBC does not have neutropenia, it actually shows neutrophilia, then evaluate for NBT, DHR, as well as lymphocyte subset, leukocyte addition disorder evaluation. Complement disorder, CH50, H50, and innate immune disorder. A lot of screening signaling pathways are there, but then if that is not available, definitely go for a genetic disorder straight away. Some small clues from clinical, the small routine investigations. Thymus absent is one. Costochondral bleeding. I'm not sure if this is very clear here. Again, costochondral bleeding is something which we commonly see and attribute it only to rickets, but this is something which we see in ADA deficient kid also. So if there is a pneumonia of child with a costochondral widening, and you think, why should this child have this? We've already supplemented, or the child is on vitamin D supplementation. Again, lymphocyte count, immunoglobulin profile, just get it done because it's very easy to pick up. These are some tests which are done, further tests which can be done in research laboratories if it is available. And uric acid being low, that also helps us in picking up PNP deficiency. The final step in the evaluation is genetic testing. So many a times we now go ahead with what is called whole exome sequencing directly. Earlier, there was targeted sequencing. So around 10 years or 15 years, when we think of Viscott-Aldrich SSM complaint as an acid probable differential, then you ask for targeted sequencing for Viscott-Aldrich syndrome. If you think of X-linked agammaglobulinemia, we get BTK sequencing directly. The problem with that is every test, even in those days, used to cost around 20,000-30,000 rupees. And that test is actually looking for only that genetic mutation. So if it is negative, so that phenotype can come in many other genetic disorders as well. So there's a child where we suspected agammaglobulinemia, kind of completely different diagnosis later. So these kind of things kept happening. And if the one test is reported normal, then the family cannot afford the next test and the tests just stop and the child dies. So this used to happen commonly. But with the last couple of years, with better genetics testings that are available, affordable to our patients, now we straight away do what is called whole exome sequencing or sometimes clinical exome sequencing to pick up mutations. It's all good as long as there is a mutation that comes up. If there is a mutation that does not come up, that does not mean that the disease is not there. It's just that our test was not good enough to pick it up. We need to evaluate further. We need to send it to better labs which tested, better investigations that can pick it up. 1. 2, the test can pick up what is called a variant of uncertain significance. This is happening pan across all specialties. So whenever we come up with something which is a variant which gets picked up, we are not sure what it is, then always further functional testing would be required. There are many challenges to what I described till now. Many a times our numbers will be normal. We do not know how to do further. Many a times we have falsely low numbers because of something other than that. Patient may have a CMV infection or drug-induced site lymphopenia. That can also cause this kind of falsely low numbers. And we are still heavily dependent on genetic evaluation because those functional testing like T-cell function, proliferation, radiosensitivity assays, etc., are not available even in very big research labs in our country. So we are dependent on next generation sequencing, and that at times may not give us correct values. So in this setting, there are now extended panels of flow cytometry that are available, which narrows down the diagnosis much further, helps us get to genetic testing much easier. And I'm just showing that this is going to be launched in the country soon. So probably by next year, we'll have access to these tests, which will actually tell us in a much better fashion than your basic TB and K subsets used to tell us earlier. And this can actually predict genotype, and this can also help us to get to treatment even before a genetic testing is coming. Few slides on management, just because we are also, as in many of these children, have to be stabilized before a definitive testing comes up. So in all those antibody deficient group of disorders, immunoglobulin replacement is important. It is given by IVIG or subcutaneous IG preparation. Subcutaneous IG is also available in our country now. So it actually don't have to admit and keep the child for an IVIG infusion anymore. So a lot of hypogammas and a lot of skid babies which have hypogamma will receive IVIG replacement. Even those traditionally not hypogamma conditions like Viscott or ataxia will also respond to a routine IVIG replacement therapy. It helps improving infections to a great extent. Children start growing well, their respiratory infections come down significantly. Only thing is, how long will you keep giving? That is the major issue. And IVIG does not help in lung, established bronchiectasis, and established gut disease also, because luminal antibodies are important there, and those infections cannot be covered by giving just IV immunoglobulin G. That is about IVIG. Then second main group of treatment is bone marrow transplant. So all those disorders that are highlighted in red require transplant for cure. And this, again, these are disorders where patients, many of them, like especially the 1, 2, 5, 9, etc., they will not survive at all without a transplant. And the earlier we get to it, before organ damage happens, the better it would be. Nowadays, donor as well as finances are not a major concern at all, because if you do not have a matched donor, either a matched family donor or a matched unrelated donor, we could still go ahead with a mismatched donor, and that results are equally good in these settings. 2, finances again are not much of a concern because these are being covered by major government schemes also. So most patients get access financial help from government for getting these treatments done. 3, there are disorders which were traditionally treated only with IVIG, and those were getting in those patients also now transplant is being considered as a modality of treatment, because you cannot put them on IVIG lifelong, because just IVIG, first of all, it just gets the cost just increases with age, with the increase in weight. 2, IVIG does not prevent respiratory gut complications. IVIG cannot prevent viral infections. CNS, enteroviral meningitis, etc. cannot be there. So many centers globally are now transplanting even XLA babies also, so that they improve. And I would like to end with these 2 papers which came out recently, which actually showed, these 2 papers which showed that children who are in PICUs, critically ill babies, who have never had a family history or never previously diagnosed as immune deficiency, and just were thought to be one bad infection which made them end up in the PICU. They also, when you evaluate, they have mutations which actually can explain it to the tune of 30%. So these are papers that are coming out now, and recognition of these disorders, recognition of these molecular defects which are there, which actually at times these defects may not be severe enough to manifest as a disease per se, but then when you have an insult like a new infection or a dengue or an enteric fever that comes on board, suddenly body's defenses fail and they end up with a critical stage. So that is something again that is being recognized recently. So now there are papers which are looking at sequencing of these children who are in PICU without any previous diagnosis, still sequencing them, so that if the child does not make it, the family needs to know why this happened. I'll end with a case just to highlight whatever we discussed earlier. He is 21 years now. He's born to non-consanguineous parents. He has had 2 siblings earlier, a boy and a girl, with exactly the same symptoms, who died at the age of 7 years and 22 years. This boy is now 21 years. This boy's elder brother at 7 years died of pneumonia against a background of chronic diarrhea. Elder sister got diagnosed as celiac disease, extremely severe diarrhea, malabsorption, poor weight gain, some surgical procedure for that gut issue, and then post-operatively had very bad diarrhea, intra-abdominal sepsis, and died. This boy, who's 21 now, was asymptomatic till 10 years of age. Then high volume diarrhea, recurrent flares of diarrhea, inter-flare fluid frequency also is like 4 to 5 per day, very poor weight gain, multiple nutritional deficiencies, evaluated as in huge big files with multiple centers having evaluated for these gut complaints. At the age of 17 years, finally, somebody diagnosed him as celiac disease, tried gluten-free diet, and that gluten-free also did not really help him much. Upper GI, when it was done in 2018 at the age of 17 years, showed an esophageal web with duodenal nodula suspicious for lymphoproliferative etiology. The biopsy showed lymphocytic duodenitis with villus atrophy consistent with celiac, and subsequently he was put on this GFD. But however, antibodies, when you check, all antibodies were low. So this is again what I'm saying, that if you don't mount immune response at all, then you can't rely on any investigation which is useful. And IgA was also low. That is again, you cannot rely on further testing at all. Again, started on GFD, nothing improved. Current weight is 34 kilos. And so we saw him almost around 1 month, 1.5 months ago, 34 kilos, 159 centimeters at 21 years of age with pan-hypogamma, some EBV infect viremia happening. So our thought process there was that, so this is something which has started not very early, but around 10 years of age, strong family history, bad gut, already, and that failing to thrive is so profound. So this has to be, if at all it is CVID, it has to be a monogenic missing, or it is an inflammatory bowel disorder totally not related to CVID, that hypogamma is actually happening because of gut losing of antibodies through the gut. So with this, we evaluated further. The lymphocyte subsets actually showed isolated low CD3 counts. The other B cell numbers were actually normal. So that was why. So this boy was picked up as CVID at another center and started on immunoglobulin supplementation. But when you look at the B cell numbers, they're pan-normal. So we can't actually go to a CVID diagnosis unless you have a below B cells being diagnosed. And that made us again worry more. On further evaluation, he was picked up as LRBA deficiency. This is again something which is pan organ involvement and pan specialities. Everybody could see such children. They come with autoimmunity, they come with hypogamma, they come with infections, and they come with a lot of lymphocytic infiltration. So that autoimmunity could be diabetes, it could be vitiligo, autoimmune hemolytic anemia, hypothyroidism, any of these things. Hypogamma, definitely with infections and any of the infections that we described. So the time that has taken to diagnosis is 11 years. He has lost siblings. He has severe failure to thrive, poor performance index, has not finished schooling till now, is homebound, and has a lot of organ damage already. So the question is, even if we want to offer treatment, it is almost impossible now to offer any treatment at this scenario. So I will conclude by saying that whenever we have patients with infections, autoimmunities, and allergies, definitely keep differentials as one of the differentials as PID, although we can keep it lower down, but still keep it and do not forget about it. Diagnose before it is too late. We learn from every single patient. If it is a patient where BMT is the curative treatment, initiate discussion. It's not so easy, difficult to get them to treatment nowadays with so many centers that are offering treatment. Correct supportive care and genetic counseling should be offered. So this is the International Immune Foundation. They have a slogan that if you hear hoofbeats, we usually think of horses, but think of zebras as well. So that is how primary immune deficiencies are described. This is my center, and I thank you all for a patient listening.
Thank you, ma'am, for a wonderful presentation. You have really simplified the topic. We have some questions. One is, can we stop giving OPV in India?
Yeah, it is high time we stopped OPV. So the follow-up on that study was, now WHO actually recommends, so and WHO, it's coming as a policy from the WHO that any patient who has, patient should be this patient. So this chronic stool carrier. So the study is still ongoing. And I think almost 200, 300 patients have been recruited from India with chronic immune deficiencies, which have chronic carriage of gut enteroviruses, including polio, have been identified. Even one of our patients also had polio, because again, this baby, known hyper IgM, family has been told that they should not receive any oral polio. Still at school, during one of those campaign, this thing, the child just gets, it just receives oral polio, and that's how bad it is. So he has now chronic carriage. So this is this has to come from top down, that we should stop and completely convert to IPV. But I think WHO is now recommending it. So it will soon come into practice.
Ma'am, anyway, as per the new IAP schedules, we give OPV only at birth, and then it's IPV only. But what happens is during the national immunization days,
we should see a CDC.
During the national immunization days, it's given to all the children.
Yeah, so that also will change. But only thing is, so why are we still having to give national immunization days is because we are expecting that there is some community carriage. And that community carriage will stop only once we stop, we clear all these pockets as well. So that is the logic, and it's a good thing that they have taken it seriously. And now the first paper on the phase 1 of the study got published, I think around 2 weeks back in Lancet. And that is, they've also brought it out in WHO bulletin as well. So now the next once the phase comes, I've been told that they're going to bring it as policy, that it should be completely stopped.
Dr. Asim has asked, what is the full form of VUS?
variant of uncertain significance. Whenever
And
there is a mutation, if it is pathogen, the ways whenever a mutation is detected, there are ways in which the people who report these tests, the bioinformaticians can actually know whether it is a pathogenic mutation or not. So if they are not sure that this mutation is pathogenic, it's just a polymorphism that has come up, then they report it as VUS. VUS is also significant because it may be that the first time this mutation is being diagnosed in our patient, and later, as more and more patients get picked up with the same phenotype, it will get pathogen. It become reported as pathogen. So these things come up very routinely in practice when we order these investigations.
Can you please share the age-related normal lymphocyte counts? We'll share this in the group.
Yeah, so I think this study, this being recorded, right? So that same paper, if you can just put the first author and say, I can also share the PDF with you, Dr. Ajay. Yeah, if you can just share it with everybody. Yes.
And what is the subcutaneous IVIG is given in what dose?
Dose is similar. Dose of replacement is what we give 400 milligram per kilogram. But the preparation, based on what preparation we have, whether we have a 10% solution or not, that then ml volume is being calculated according to that. So that
Dr. Namrata has
preparation is available. You could calculate it for your patient. It's still not a small one. Yeah.
Okay. Dr. Namrata has asked, an 8-month-old baby has recurrent fever and thrombocytosis. So what can be the possibility?
Thrombocytosis is usually reactive. So if the patient is coming with recurrent episodes of fever with significant thrombocytosis, the first thing we should look for is an underlying abscess, an underlying infection, a persistent pneumonia, something which we have not picked up at all. And that is usually, and the majority of thrombocytosis we see is either reactive to infection or reactive to deficiency, which it has hardly anything else.
Any critical patient admitted in the PICU with very bad infection, should we keep the PID in mind in all these cases?
Yeah, I wouldn't say initial differential, but yes, it has to be kept in mind, definitely, like Dr. Ajay said. So this is important. If the child improves, definitely on a later date evaluation for immune deficiency should go hand in hand so that this does not come back again. If you think the child will not survive, it would be a good idea to just do the beginning screening evaluation and keep a sample, a DNA stored with you, so that if something comes up in this, you can definitely evaluate further.
Dr. Dinesh, would you like to ask?
Yes, Dr. Dinesh.
Dr. Dinesh, you can talk. Please unmute. Anyway, there's one more question. How early can an isolated B cell defect be identified?
Yeah, B cell defects usually, like I said, it comes after 6 months of age. So till 4 to 6 months, maternally transmitted IgG is enough to cover for infections. So it's usually around 6 to 8 months, then they come with start getting their first infection. So that first infection could be a pneumonia, it could be an ear infection, that kind of presentation. And you can't really pick them up from a CBC because B cells are actually a very small fraction of the total lymphocytes. So it's usually, if you're suspecting and your CBC either shows slight lymphopenia or normal lymphocytes, please go ahead and get an immunoglobulin profile.
Thank you. We have Dr. Jagdish Chandra sir with us. I'd like to have some expert comments from Dr. Jagdish Chandra sir. Sir.
Good morning, sir.
Thank you. Yeah, actually, I can't give expert comment after what Nita has spoken about this topic. This topic is actually hers. In the city of Delhi, there's hardly anybody who talks about this topic that well. And really today, you did a wonderful job by describing several cases and highlighting. And just to reiterate, highlighting the importance of not the history alone of infections in the family, looking at the cytopenias, the history of maybe something like ITP and the AIHA and malignancies and HLH, and that would all, should point out towards the etiology which might be primary immunodeficiency disease. So a little question for you, Nita. Over the last, I think, two years or so, during the COVID and post-COVID times, what I have observed is that a lot of cases of tuberculosis are being seen. So, in fact, when I was at Basai, we even started a thesis on this. A lot of tuberculosis with the, you mentioned that the profile is slightly different, maybe more disseminated, kind of more problematic cases of TB. And exactly that is what we were. Once we were having a differential diagnosis between a CNS tumor versus tuberculoma, very large tuberculoma, which usually we see a disc lesion, say 1 inch or so, something like that. But it was a huge, and finally we landed up with tuberculosis. So the profile is different and more extrapulmonary tuberculosis. Do you also have a similar kind of experience, more cases, coming in such a situation where you think of PIDs more often? Or maybe the immunodeficiency workup is required more often than what used to be earlier?
Not as in for PID workup, there
Or maybe
has been the number of patients being sent for PID workup is. Yeah, I think there is COVID definitely, sir, because I have heard this from many others that post-COVID they're seeing many more tuberculosis, like a couple of our patients also, when there is nothing else, and we've discussed it with senior pediatricians, they said just give ATT because we are seeing small things which improve only with ATT. So that's been our experience also. I think there is some kind of an acquired or a immune deficient state post-COVID that is happening, and that is causing this. COVID per se should not be as in COVID predilection as primary immune deficiency causing COVID predilection is not much at all. There are only very few variants that have been picked up that has predilection to COVID per se, and they are not in the classical primary immune deficiency spectrum at all. But anybody who has developed a COVID has some kind of an acquired immune deficiency state for a couple of years, I think, and that is contributing these weird infections.
So just in that connection, maybe is it like whatever the immune processes are in the body, and during their maturation, the role of the commonly acquired infections by the children, which they did not acquire because of the lockdowns, could that have a role to play in such situation?
And in immunization also went down significantly during the lockdown period. So many of the re-emergence of infections could be because that these children were not immunized on time.
Thank you.
Thank you, sir. You are muted, Dr. Ajay.
What are the common allergies that go on to PID?
So there is no real as in common, as that paper did not describe that part of it. But yes, children who have the PID patients, when they will look back to see if there are allergies, there are mainly bronchial asthma was the main thing that came up. So food allergies as well as bronchial asthma was a major presentation. But we have seen skin also as a significant thing. A lot of kids, not just the viscot group of disorders, but even otherwise, there are a lot of skin allergies that are there in children with immunodeficiency.
Dr. Vikas Talware, ma'am, I have two siblings, male with SGIA and younger sister with chronic ITP. How should I approach?
To get again, a boy and a girl, so unlikely that it's X-linked disorder. But if there is OGA and chronic ITP in two children, there should be something which is a unifying diagnosis should be there. So if your basic immunoglobulin profile and lymphocyte and neutrophil counts are normal, it might be, if there is, especially if there is consanguinity, siblets, etc., it might be better to get a lymphocyte subset first, and if that is normal, a further genetic evaluation done. This chronic ITP kids, not this girl, but boy with chronic ITP, we have been traditionally taught to look for viscot Aldrich. A girl with chronic ITP, CVID should also be part of the evaluation. These are two immune disorders.
But if there are more questions, we'll let you know and we'll post them in the group. So thank you very
Thank
much
you.
for a wonderful presentation once again. And I thank all the delegates also who joined. Thank you, Dr. Jagdish sir and Dr. Kamaljeet ma'am. Thank you very much.